everyone, and welcome today to today's topic of working with clients with brain injury and psychological considerations and de-escalation. The BIA main chapter gratefully acknowledges partial support for this training series for the Administration for Community Living, the U.S. Department of Health and Human Services. To ask a question, we please ask that you type your question in the Q&A box of your control panel, and at the conclusion of the presentation and moments during the presentation, I will read as many of these as possible to our presenter. Our presenter today is Dr. Douglas Gomez, Assistant Research Professor working at the Center on Brain Injury Research and Training, CBERT. His interests primarily focus on methods of qualitative analysis, particularly in the service of benefiting traditionally underserved populations. At CBERT, Doug currently works on studies with the goal of reaching a better understanding about how patients, educators, coaches, and medical professionals can help facilitate improved services for individuals who have sustained a TBI. He is also a licensed psychologist with experience working clinically in state hospitals and correctional facilities, which instilled in him a firm belief in the importance of research informing practice. Welcome, Dr. Gomez.
Thank you for having me. All right, so I will go ahead and get started. Let me see here. Go ahead and get my presentation going. Let's see. All right. Does that show up okay for everybody? Okay, cool. So today, so if you were at my first presentation, I talk a lot about kind of just brain injury 101, and also just the ways in which brain injury accommodations can be completed. This is my favorite presentation. This is like the one that's nearest and dearest to my heart. It's sort of thinking about psychological considerations when it comes to brain injury, specifically referring to certain diagnoses. And then also I'm going to be talking a lot about de-escalation. So we've kind of done some intro here. This is who I am. Mainly just want to note that my de-escalation experience primarily came up within these settings clinically. I did some trainings. I've done been a part of a lot of different de-escalation training. And I've also had like quite a few situations come up that just made me go, this is something that we need to talk about. And especially when it comes to brain injury, this shows up quite a bit with some of the symptoms that I mentioned this previous week. So excited to talk about it with y'all. All right, the way that I'm going to start off is with just talking about mental health concerns. There are quite a few different mental health concerns that are associated with brain injury. I talked about it a little bit last week, but when I say associated, I mean you can have mental health concerns before you sustain an injury, and those can be exacerbated. You can also have brand new diagnoses as a result of a brain injury. The primary ones I'm going to be covering today are mood disorders a little bit. I'm going to be talking about suicidal ideation a little bit in that context, anxiety disorders, PTSD, a little on substance use disorders. And I've actually also added, because I did a presentation for the state hospital out here, and people who work, if you're somebody who's worked at a state hospital, all they want to talk about is psychotic disorders and what that looks like. So I added a piece in here that's relatively newer, but I think it's helpful to get a sense of. All right. So the thing that I first want to do always when I'm talking about this is just look at DSM-5 criteria. The reason is not to like intimidate people or make people feel like, oh, I need you to memorize all of these things if you want to work with folks with brain injury. It's just to note that each of these diagnostics, each of these diagnoses in themselves have something that should make people think about brain injury when it comes to these symptoms, something that can be difficult with differential diagnosis specifically. So in this case, looking at major depressive disorder, I'll just have you note that part of the diagnosis of major depressive disorder, one of the symptoms is executive dysfunction, certainly some suicidal ideation, and then some psychomotor agitation are all part of a diagnosis of major depressive disorder, which makes this really tricky when you're seeing some of these symptoms for folks with brain injury and you're trying to make a differential diagnosis. You're trying to determine what is going on, what came first, chicken or the egg, this kind of stuff. Also with mood disorders, a couple of things to note. It is the most common mental health concern post-TBI. There is a very frequent development of a mood disorder without a pre-injury history, meaning that what I said earlier is really important with mood disorders. Even if you had no history of a mood disorder, if you sustain a brain injury, you are very likely to also have or meet criteria for a mood disorder as well. I mentioned this comorbid presentation with anxiety before in my last presentation, but it comes up all the time. You'll see some form of mood disorder and anxiety as well. And then this bit, you're 4 to 6 times more likely to be diagnosed with major depressive disorder post brain injury compared with the general population. If you need numbers, some people are numbers people. These are good ones to report on. All of this data, by the way, comes from epidemiological studies. There's a couple right in the later portion that I'm going to talk about that are not epidemiological. They're more population-based studies, which is actually really important to look at too. So I'll cover that. Another thing to note, just again, looking at DSM criteria, right? Look at these bottom few bullet points for generalized anxiety disorder. So we have difficulty concentrating, mind going blank. We've got irritability, and we've definitely got some sleep disturbance. So again, when people are looking at how do I compare a generalized anxiety disorder symptom with something that's a brain injury symptom, it's not so easy. I'm going to talk about sort of some of the things that I do that are helpful for me when it comes to just this differential diagnosis. PTSD, I very much apologize for this slide. There's a lot of bullet points in the DSM. Just kind of want to note some of these bullet points are going to sound a lot like similar to brain injury symptoms. And I'll show you a better example of this, I think the next slide. But just noting difficulty falling or staying asleep, reckless or self-destructive behavior, irritability, difficulty concentrating. So hopefully I've sold you enough to at least come with me on, hey, there are some symptoms with mental health conditions that look a lot like brain injury. Speaking of which, this comes from my work with veterans. I call it the complicating matters slide, but just trying to get a clear sense that there are diagnostic criteria that people can think are PTSD, think are TBI, can be caused by both. It shows up a lot if you are working with veterans. This is an important slide to understand also, because when veterans are looking at getting disability, this is definitely a topic I feel really passionate about. And so I'm not going to go super long on it because I know that I can, but I'll just say when it comes to disability ratings for veterans, if that is a population you work with, you really want to understand what symptoms are associated with PTSD, what are typically associated with TBI, and where's the overlap, because it can make a huge difference for people. This other slide that I've added, why I really like it is, so if you're looking at epidemiological studies, particularly like this Ponsford study I'm referencing, they would argue that there isn't a significant correlation between psychotic disorders and brain injury. And the problem with that is, you know, with any research, you're looking at cross sections of people, and you're saying at this given time, we didn't notice this relationship, but population-based studies that are looking at like large scale data, why we call it the Swedish study or the Danish study, is they're looking at huge swaths of data, and they're comparing, okay, what are the relationships between people with brain injury and some of these symptoms? We do notice a significant relationship. And I kind of just want to draw your attention to this second bullet point, especially. After the study, this is the Danish study, controlled for gender, age, year, presence of psychiatric history, epilepsy, all these different things, individuals with a TBI were significantly more, 65% more likely to receive a diagnosis of schizophrenia. And so just, again, it's all about where you get your data, but it's something to note that you will see cases where people sustain a brain injury and they're likely to receive a diagnosis of schizophrenia or other psychotic disorders. Also, the symptoms you're most likely to see with psychotic disorders and brain injury are persecutory delusions, auditory hallucinations, and those are the ones that come up the most. So you can kind of see, if you've got folks who are having persecutory delusions, it would make sense that they may receive this diagnosis of schizophrenia. All right, so why is this all important? When it comes to, again, I gave a whole bunch of data, there's a lot of relationships here, but why it's important is that the way that we work with folks with mental health conditions and brain injury can be really tricky. I've worked in spaces where unfortunately, been a part of systems where you'll have somebody with a brain injury. The first thing is they'll go see a physician, and the physician will say, okay, here's the symptoms that we've noticed. Maybe they're not showing up. There's not showing up like really significant issues, structural issues in their brain. And so I'm noticing their primary symptoms are anxiety and depression, for instance. I think they should go see a therapist. They go see the therapist. The therapist goes, well, you sent me this person, but you sent me them because they have a brain injury. Brain injury isn't something that I can help with. Like I can't, make them better heal this injury. They'll send them back to the doctor or the physician. And there's a lot of just bouncing back and forth. And so for me, part of the reason I like talking about this issue is that it's important to note that there are things that can be done psychologically, particularly if you're any sort of like counseling or therapy, that make a huge difference for folks with brain injury. All right. So the biggest piece for me are just thinking through symptoms. How do I think through like what's happening with this person? How can I help? Always think in terms of symptom clusters. So I showed you these DSM criteria for mental health concerns. If you were to just look at a concern, like for instance, if I were to talk to you about memory as this example I've given here, right? And so I'm working in this space, we're talking about memory. I'm going to make an assumption that the memory issues that a person's going to have when I'm working in a substance use disorder facility, I'm going to say, yeah, maybe that's related to alcohol use, or maybe that's related to opioid use or something like that. I brought this up in my last presentation because the context you're in matters a lot. And if you just look at one symptom, you can be sort of misled when it comes to diagnosis. If you're working in a different facility where you're seeing folks all the time with brain injury, and then they have an issue with memory, your first assumption might be, hey, we're talking about a brain injury here. Let's do an assessment for brain injury. The problem is, as I showed before, issues with memory are strongly related to major depressive disorder, strongly related to generalized anxiety, strongly related to PTSD. And so just looking at any one symptom, it's not enough information for you to get the whole picture on what's going on with somebody. So definitely look at symptoms in terms of clusters. How many different symptoms does a person have? What criteria does it meet? Also asking questions about timelines. So if a person was depressed, and like let's say you'd been working with them for a long time, they're reporting depression for an extended period of time pre-injury, and then now they've sustained a brain injury and they're reporting their depression's gotten worse. That's really important information to document. And the same goes for somebody who has no history at all of anxiety issues, and then all of a sudden they sustain a brain injury. You're noticing, hey, this person's much more anxious. Rather than assume that you have this like spontaneous generalized anxiety disorder that came up or social anxiety, let's also pay attention to, hey, maybe this brain injury is related to these symptoms. The only other piece I really like to talk about when it comes to thinking through symptoms is just that brain injury, in a lot of cases, I talk about it as a paradox. When you're talking about my favorite example is this second bullet point. So you might have a person who sustains a brain injury. You might have two people, right? They're sitting in the same car. The car gets in a wreck. They both are end up with brain injuries. They're diagnosed with brain injuries. One of them, if you sit them in a group, let's say it's a support group or something, the entire group, they might not say 10 words. And most of the time they're looking with kind of a confused look on their face. It seems like they're having trouble processing. That is one symptom cluster, one group of symptoms associated with a brain injury. The same person who was in the same car with them had an issue, like sustained a brain injury. If you put that one in that same group, you might also notice that person doesn't stop talking, doesn't have good indicators on like when it's their turn to talk. Maybe they're like saying impulsive things. Maybe they're getting irritable really easily as a result of conversation. Two people, same injury supposedly, right? They both sustained brain injuries, but you might see totally different symptoms on either side of the spectrum. Recognizing that when you're working with folks that you've seen one brain injury, and that just means that you've seen one brain injury. Making generalizations based on the one brain injury you've seen is definitely not recommended. All right, let's see here. Other assumptions that people make quite a bit, especially when you're working with folks like therapeutically. The most important work I can do is assessing for cognitive deficits. I need to help this person get better at attention, better with their memory, better with their language, etc. The reality is, like, depending on what your role is, if you're a therapist who's not trained in, cognitive restructuring, or you're not trained in different methodologies that do actually benefit somebody's attention and memory, there shouldn't be an expectation that that's what you do. It doesn't mean that you're not going to be helpful to a person with a brain injury, though. It just means that you have a different focus. You might be able to help them with emotion regulation or distress tolerance or something like that. So the most important work is just doing what that person would benefit from, asking them what they need, having those conversations. Similarly to the second bullet point, it's not necessarily about regaining function. It's about how can I help this person given the skills that I have. The other phrase that I hear like way too often when it comes to brain injury, and you all may hear this quite a bit also, the person is being resistant. This person in front of me is being resistant. They're not participating in treatment the way that I'm asking them to. Maybe they're showing up. I was sort of brought up, my part of my psychological training was the psychodynamic. And so this idea that a person is showing up late for every appointment is actually like, I was taught that, hey, maybe consider the reason they're late is actually that they don't want to be there. They're communicating something else to you with this behavior, right? And then you'd write down things like patient is resistant. They showed it by, showing up 10 minutes late for every appointment. With folks with brain injury, it doesn't necessarily have to be resistance. It could be that they don't have their executive function working the way that they need it to, and they need to, they need alarms set. They need like someone to help with their calendar. They might need more organization. And so making the assumption that somebody's being resistant is a little too easy, and it doesn't provide for a whole lot of empathy for that person that you're working with as well. The other thing that I just mentioned, I call it the behavioral therapy trap. There was this idea that for folks who had a brain injury, that the best way to work with them is to only use behavioral therapy. So like reinforcement, the types of things that you would use in training, if you were like training an animal or something like that, a pet, right? That's the kind of work that you have to do with these folks, because they're not going to have the function. The assumption is they're not going to have the insight possible to be able to benefit from therapy, or they're not going to have the ability to like make these connections. And the reality is, and both anecdotally and born in out of research, that is not an accurate assessment of folks with brain injury. So making sure that if you have behavioral therapy, if that's something that you do in the work that you do, awesome. That's a great technique. It is not the only technique that benefits folks. All right, so what can we do? I mentioned kind of the importance of just listening to talk to folks about like what they want to work on, what are the things that they want help with. I've sort of oriented this more toward like therapy, but the reality is, if you're an OT, if you're somebody who works in a space where you see a lot of folks with brain injury, maybe peer support, those kinds of things, just listen. Like it's our most valuable, most effective tool, especially when I start getting into the de-escalation piece in a little bit. Like listening breaks down so many barriers with this work. When it comes to working on trauma, there was this belief at one point that a person couldn't have PTSD and brain injury at the same time. There was this thought that if you can't remember the incident fully, then how could you be traumatized? Which again has been fully debunked. There are so many folks with PTSD diagnoses and brain injury look within our veteran population. And so there are plenty of effective techniques like cognitive processing therapy, prolonged exposure, things that work for trauma in general that also work for folks with brain injury. I recommend for folks that if you're going to work with somebody with brain injury, get acquainted with grief and loss work. Get acquainted with, how do we have conversations about healthy loss and processing loss and grief? Because one of the things that walks through my door more than any other with folks with brain injury is this idea that I've had this loss of functioning. I am not the person that I was, even in some cases like weeks before. And so that requires some processing. That requires some actually taking a look at yourself and going, okay, what are the pieces that that I need to process in order to come to grips with the fact that I'm not the same person that I was a few weeks ago, and the things that I'm working on are going to just benefit me in a much more powerful way if I treat it as a grief and loss, like there's a loss here. Other traditional therapeutic modalities, things like DBT, I mentioned emotion regulation and stress tolerance, are really effective. Do not get caught in the behavioral therapy trap as the only thing. If you have techniques that you use that are helpful, I promise you, you can find ways to accommodate folks with brain injury. All right. Let's see. The other piece that I talk about is just before you can even think about brain injury, you have to screen for it. I talked about this in my last presentation a little bit, so I just want to highlight it. Like, screening does not have to mean you're doing only using the OBIS, which is awesome that Maine has it. It does not mean that you only need to use the OSU TBID or only whatever you have available. Just ask questions about brain injury. Rule out, revisit further along too. If someone said, hey, I got in a car accident last week, you assess them that first week. The following week when they come in, ask more questions. Hey, have you noticed any cognitive issues in this like last week? Have you noticed issues with balance, or like ask about both physiological and psychological symptoms. Stay open to consultation. I referenced last week that I did a needs assessment for the state of Oregon. The average number of individual supports and services a person with brain injury required was 12, which is a really large number. So when you're working with folks with brain injury, just know that they're going to be and they will benefit from being in multiple spaces when it comes to rehabilitation, when it comes to managing mental health. All of those supports and services are not physiologically based. They're not going to be like only, oh, you have to see a neurologist and then a psychiatrist, et cetera, et cetera. Like, these are things like getting connected with support groups, getting connected with occupational therapists, OT work. Like, there's a lot of different individual supports. So just be open to consultation and collaboration. The other thing that I love talking about, it's like one of my favorite metaphors for people, so take it or leave it, is when people are talking about brain injury, a lot of times they talk about how long does it take a person to bounce back? How long does it take them to bounce back and get to the person that they were previously? And I saw this phrase, it was probably something I got in like a counseling textbook related to brain injury, but this idea of bouncing forward, and I love that. Like, if you take nothing else from my presentation, like, thinking about working with folks with brain injury as bouncing forward instead of bouncing back, not trying to get back to where people are, but framing the work as, okay, here's where we're at. What are we looking to in the future? What are goals that we can set that are realistic and consistent with your goals? It's not to say that I discourage people from saying, hey, I want to get back to how I was before. It's just that if you frame it as, hey, we're not trying to get back, we're just bouncing forward. We're just looking at what are next steps that are appropriate. Sometimes it can make a huge difference for folks. I have had folks argue with me like, no, I'm just trying to get back to where I was, which is fine. Like, the framing is valuable insofar it's valuable to the person sitting across from you, but just it's been a helpful one for me in this work. I'm a psychologist, so obviously the best recommendations came from the APA, except that when I looked at them, they actually weren't. The best recommendations I found were actually from the ACA, American Counseling Association. These were awesome for folks with brain injury. Again, it's one of these situations where if you take nothing else, these are really, really valuable bullet points. So recognizing being comfortable with silence, adjusting your pace. I talked about this last time based on your client report, just recognizing that, like, if you have a person with brain injury sitting in front of you, you may need to provide accommodations just based on the amount of time that you're working with that person. So if it's, if they work for 15 minutes and they start to feel overwhelmed, give them 15 minutes and then do a grounding exercise, take a break, and then come back to whatever you need to come back to, but adjusting based on client report. There's a lot of research out that talked about recovery for brain injury concludes after 2 years. This has been like a misnomer forever. It's actually just a generalization. Like, a lot of times when people are talking about recovery not improving after 2 years, they're talking about like structural brain recovery, like the things that we can note in a scan. The reality is recovery just can be a lifetime of experience, and it does not stop after 2 years. So if that's something that people are talking about in your spaces related to brain injury, hopefully you'll push back a little bit. And then I talked about this last bullet point, but it's an ACA recommendation. Just be open to working with other folks. All right. I want to pause there just because I've talked about a lot. These are really important psychological considerations. And so I want to check in if folks have any questions or any things they want to bring up in the chat.
Yes, Doug, thank you. We have two questions here. Kathleen said she had a question regarding post-TBI MDD diagnosis. Is that because some clinicians may be looking for the MDD after a client patient sustains a TBI?
Yes, that is a really important point. Thank you for bringing it up. It is mostly about like you are more likely to receive this diagnosis because after a brain injury, you're going to show signs and symptoms that meet criteria for major depressive disorder. My bias, my argument is being aware that a brain injury can look like major depressive disorder and then doing your due diligence, asking about other symptoms, making sure they meet criteria for other reasons, because giving a person a major depressive disorder diagnosis is not always going to be incredibly helpful for them if the only time they noticed the symptoms was post brain injury, and especially if it was like acute symptoms. So someone noticed these symptoms for the first couple of weeks and then they're starting to resolve. That does not meet criteria for major depressive disorder. So important to note those things. Great question.
All right, great. Thank you. We also have two questions from Maria, so I'll read the first one. The first one says, I've noticed in working with clients who have experienced a brain injury, the sudden onset of panic disorder symptoms. Is this something that has been documented or that you have observed in your research/clinical observations?
Yeah, absolutely. There are more potential for panic attacks, more potential for a panic disorder diagnosis. There are also, I do recommend if folks are like research oriented at all, this epidemiological study I included in my notes, this Ponsford study is actually pretty solid and the language is pretty solid too. So like if you'll go through, you can actually look point by point, like paragraph by paragraph. Here's the epidemiological data we have around anxiety disorders and panic and the different ways that it gets diagnosed. And it's really helpful to get that information. But not just anecdotally, but also research-based, you are more likely to be diagnosed with panic disorder post-brain injury.
Great, thank you. There's a second part of that question, but I think you've answered part of that already.
Okay.
She says, I've also noticed a rise in vertigo symptoms co-occurring with panic after a brain injury. Is there a documented relationship between these symptoms that you're aware of?
Yep, 100%. And so if you have a panic disorder and you have panic attacks, dizziness is one of the primary symptoms without a history of brain injury. If you add brain injury into the mix, you're much more likely to have that be one of the primary symptoms. So just noting, being aware of those two things, but also, again, when it comes to diagnosis, I'm always really careful about when I diagnose, because if you're doing what I recommended earlier, which is looking at the timelines for symptoms, if a person had no history of panic symptoms pre-brain injury, and then they had a brain injury, it may not be helpful for them to receive a panic disorder diagnosis because you've noted that, hey, this is much more related to a brain injury. So just kind of paying attention to those things, I think, is really important.
Great, thank you. We just had another one come through. How do you deal with patients who have memory loss and get frustrated about the loss?
Yeah, I could spend a lot of time talking about this one. It is, I mean, this bounce forward idea is really important. So the two things I do, it's accommodation, right? So trying to help them create built-in structures that benefit those folks with some signs of memory loss, particularly working memory loss, is important. But then when I talked about like grief and loss and processing, part of that too is dealing with the loss of like your functionality when it comes to memory. I see it a lot with older adults. You sort of like help people come to grips with the fact that this, in some cases, this is a natural, normal part of aging. If you have folks with brain injury, this is a natural, normal part of healing, and the process of brain injury as well is just to be working on memory. And again, sometimes people get caught up in like you're after 2 years, that's it. You can't recover anymore. I highly, highly recommend debunking that for the person sitting across from you. Like you can make. I worked with folks for longer than 2 years post injury and saw just drastic changes, even in just compensatory strategies and improvements in working memory. So a lot of it is like normalizing that for them, and then recognizing that also this is the other piece I always mention. Things like anxiety and depression exacerbate memory issues. So if you are noting that you're taking care of yourself, you're going to see a therapist, you're like spending time, you're engaging in self-care, you're spending times in ways that are consistent with like feeding your soul, you'll actually notice improvement in memory over time. And it's just that you don't have all these other competing mental health concerns that are impacting you and impacting your memory as well. So like, I don't know, I encourage people like taking care of yourself actually, both physically and psychologically, actually you'll benefit memory as well. But it's challenging. This is a topic, again, it's another one I feel pretty passionate about. It could be a long conversation.
All right,
All
thank you.
right,
That's all for now.
awesome. So with that said, this next part, I'm going to go into a little bit more de-escalation. Here's my caveat to de-escalation with brain injury. People go about it a lot of different ways. There's sort of like broad de-escalation techniques people talk about. For me, de-escalation with brain injury is a lot more about like, it's kind of goes on about what we'd consider micro skills of counseling. So when I'm thinking about and talking about micro skills, I'm referring to like, how do we manage our like our well-being, our face, the way that we're presenting ourselves, and sort of just thinking about like, what are the ways that we can present ourselves to another person? That's really important. Okay, so some key concepts here. Reasoning with an angry person is not possible. I'm actually going to have to take a pause real quick and just get a glass of water. It'll take me like 2 minutes. One moment. All right. All right. Sorry about that. I get ahead of myself sometimes. All right. Let's see here. All right. We're seeing the key concepts. Okay. So key concepts when it comes to de-escalation. Reasoning with an angry person is not possible. When I think about de-escalation, a lot of times people think about like, if I could just say the right thing, if I can just act the right way, then this person will de-escalate, and they'll improve, and we'll be able to have a conversation. The hard thing is when a person is so escalated, I think about things as like a 0 to 10 scale. If a person's up at a 10, they're not able to interact with you. They're not going to be able to hear what you're saying. The logic that you're using is not going to be incredibly effective. And so I recommend just the goal of de-escalation actually just being, how do I bring this person who's at a 10 down to a 5 so we can have a conversation? The other piece that goes along with this, though, is that de-escalation techniques are very inherently abnormal. They're really, really challenging. And so giving yourself grace and recognizing that de-escalation, especially when it comes to working with a person with brain injury, it's not a natural, normal part of our development. It's not a thing that we like learn as we grow. And so it's important to just note that it's hard. And again, give yourself grace in that process. Empathy is like the most important thing. When I think about de-escalation and I'm talking about like, what are the things I would want somebody to remember when it comes to de-escalation? If you can just recognize that the person sitting across from you is struggling, and that especially if they have a brain injury, these are signs and symptoms of brain injury, de-escalation is going to be made significantly more easy in that process because you're going to be more likely to want to engage with that person in that moment. There are quite a few precipitating factors of de-escalation. Um, the thing that I like to point to on this slide is just recognizing that things like pain, things like overall discomfort, feeling fatigued and hungry, all lead to escalation. When it comes to folks with brain injury, it's not just, oh, this person's lacking impulse control and therefore they're incredibly escalated all the time. Sometimes it's just noting the person's in pain, they haven't eaten. You know, there are a lot of different factors related to de-escalation, to escalation, things that will escalate people. Anxiety and depression are another huge one that people need to be thinking about. When people are anxious, they're much more likely to be escalated. The hardest one, and the one that I try to advise against, is just this desire for attention. Um, I think sometimes people use desire for attention as a crutch, and they say, you know, the only time this person gets escalated that I'm working with is when they want attention. Sure, maybe that might be the case some of the time, but just recognizing there are so many different precipitating factors, desire for attention is like one of the last ones that I think about. And honestly, again, people use it as a crutch. People will say, you know, the only time this person ever gets escalated is when they want attention, and they don't consider fatigue, discomfort, pain, issues with impulse control as well. So I don't know. I don't love that one. I try not to use it that often. Other environmental precipitating factors, particularly for folks with brain injury, overstimulation, confusing visuals. I worked at a place that was supposed to be serving folks with brain injury, and they had this big sign right out in the front that had all these like different colors and arrows pointing different directions, and it was supposed to give people like a good understanding of what it's like to be in that place, like all the things you need to know about working in that one location. It was fully overstimulating people. Like nobody used that sign. It was not effective. Once someone actually pointed it out, we were like, yeah, we need to take that down. It's not helping people with brain injury. So recognizing overstimulation as a part of escalation is huge. Problems in interpersonal relationships. And then the other thing that I always tell people, and this is a hard one, I think, for people, um, if you can't figure out the trigger, sometimes the trigger might be you when you're working with somebody. And so being willing to ask questions like, what can I do? What about the way that I interact with you would be helpful? What have you noticed that's not as helpful? Is a huge part of these precipitating factors. The story that I always tell is like my first day working in corrections. I was standing behind another therapist just shadowing, and I noticed that every time that I came into view of this person, the conversation started to go more poorly, and I could not figure it out. And then finally, the patient at the time was like, yeah, this guy behind you reminds me of my brother, and we've been fighting for a long time. And it was like, oh my gosh, like I was definitely the trigger in that moment. I was the thing that was escalating that situation. And so being willing to sort of take that on, not take it personal, is really important when it comes to de-escalation. All right, when it comes to brain injury, just some general notes to be thinking about. Up to 80% of patients experience agitated behavior as a sign, symptom of brain injury. And that can be physical aggression, that can be comments, that can be like restlessness and just general mood lability, up real high highs, real low lows, those sorts of things. But they're all associated with agitated behavior. Resolution varies, but can persist during the first 2 to 4 weeks post-injury. The reason I mentioned that is what I was talking about earlier around acute symptoms. Just because a person that you're interacting with is challenging in their first couple weeks, first 4 weeks post like acute stage of a brain injury, doesn't mean that it's going to maintain over time, but it can. Also, disorientation, confusion, other sequela of brain injury like issues with impulse control, absolutely can lead to escalation. When a person's feeling confused and disoriented, a lot of times their first response is aggression because it makes them feel safer and in control. All right, I'm not going to belabor the point on this one, but I'll just note that there are some specific signs of agitation. The one I really want to key in on, though, is balled fists. I talk about that one a lot. So when I was working in a state hospital, we would go back and we'd do this whole debrief process after there was any incident involving violence. There was a period of time where we could go back. I think it was probably like 5 incidences in a row where before the violence occurred, you could actually see that a person had their fists balled up. So why that's important, it's not actually a situation where you see somebody and their fists are like up around their head, kind of that like cartoony, I'm about to fight thing. When you see balled fists, a lot of times it's people with their arms to their side, and you can see them sort of clenching their fists to show that they're feeling agitated. So just as like one of the primary signs of agitation to pay attention to, particularly when it comes to violence, pay attention to balled fists. All right, so I've talked about a lot of the like different precipitating factors when it comes to de-escalation. So I want to talk about these micro skills that I mentioned earlier. So much of de-escalation is about the micro. It's about like, what are the ways that I'm presenting myself to this person across from me? One of the first things that you can do is just try to present yourself as calm. I mentioned that these scenarios are inherently challenging. It's like not a part of our general sort of physiology to be able to de-escalate. So presenting yourself as calm can be really challenging, but it can make a world of difference. Selecting an appropriate location is another really big one when it comes to nonverbal techniques. So just noting that like if you're out in front of a lot of people, you're more likely to escalate a situation. If you can find a space where you can pull someone in and have a conversation, you're much more likely to be successful. Maintaining limited eye contact and a neutral facial expression is a huge part of de-escalation as well. Maintaining an alert posture. I always tell people like try to match levels with people. So if somebody is sitting down and they're escalated, sit with them. If they're standing up, stand with them, but just try to match. Managing the way that you speak to people is another huge part of it. And then positioning yourself for safety. I think I have a slide on this. Yeah, so positioning yourself for safety is a lot about just making sure that when you're de-escalating, you want to make sure that you're not blocking an exit. You want to make sure that you are keeping yourself in a safe location so that you're like maybe an arm's length away. You want to make sure that you've kind of matched levels with people like I was talking about. Positioning yourself for safety is just be thinking about safety as you're engaging in de-escalation. All right, other things to consider is just controlling your breathing. When people feel stressed, like when I'm doing a presentation in front of folks, I note that my breathing is way more shallow. It's just a part of the work that we do. When I feel anxious, when anyone feels anxious, we have to take deep breaths because we know that our breathing gets a lot more shallow. When it comes to de-escalation, taking a deep breath can make all the difference. Controlling your voice and body language is key. When I say control your vocabulary, really what I mean is just try not to use language that can be inflammatory. So using words that are like using like curse words, even if it's part of your vernacular, can be really problematic when the goal is de-escalation. And then also calm is almost as contagious as fear or panic. So when someone is feeling like panicked and then they're walking into a situation where they need to de-escalate, unfortunately, a lot of times they'll escalate the situation. So just exuding a sense of calm is a huge part of de-escalation. All right, I talked about positioning yourself for safety a little bit. I want to get into some verbal techniques. So the biggest thing for me with verbal techniques is just, it's less about what you say and more about how you say it. So not interrupting folks, trying not to get defensive, trying not to argue or persuade is a huge part of verbal techniques. Additionally, validating is probably the most effective tool that you have when it comes to verbal techniques. The key with validation, though, is that you don't want to empathize with a behavior. So an example might be you have a person who's in a space, they threw a chair, right? That was their behaviors. They threw a chair. Validating doesn't look like going in and saying, I know why you threw that chair. I would have done the same thing in that circumstance. Validating would be saying, I've felt angry before. I've felt angry enough to be able to do something that's not consistent with my values. And so I'm validating that I understand how you could get to the point where you got to. I'm not still supporting your behavior. Also important is responsive listening skills. So kind of acknowledging, apologizing, agreeing, inviting criticism are all really key. The biggest thing with all of these techniques is that you want to be open to what comes up. So if you made a mistake, be willing to say, hey, I made that mistake. I'm going to own that in this moment. If a person says, hey, it wasn't fair that this and this and this happened, if you agree with them, that's a great way to de-escalate. Just saying, hey, I agree with what's happening in this moment. I agree that that wasn't a fair situation. That's a great technique for de-escalating. And as long as you're being honest, it can be really effective. Inviting criticism, being willing to take and receive criticism from somebody else is another awesome technique when it comes to de-escalation as well. Reminder though, is just being really cautious and careful about your tone of voice. You can say all the right things, and if you say it with the wrong tone of voice, that's where you create an issue. All right, the last little piece is just this bit about ending de-escalation. So when a person has calmed down, you can start having a conversation. Until that moment, all you're doing is de-escalation. So if somebody's up at a 10 and you're having a really hard time bringing them down to a 5, that's not the time to start bringing up all your logic arguments. That's the time where your goal is just to calm, slow, careful voice, make sure that you've gotten to them in this calm place, and then we can start having a conversation. I also always tell people you have to trust your instincts when it comes to de-escalation. There are a lot of moments where people will say, I didn't feel safe for some reason, and so I left. That's a totally fair way to interact with somebody. If you're not feeling safe in the moment, saying, I'm going to need to excuse myself, I'm going to bring somebody in to have this conversation, someone else in to have this conversation, that trusting your instincts is a really important part when it comes to de-escalation. If it's not working, stop. I tell people, I have a slide on this right at the end, but just if you're working in a team, the best thing that you can do is if you're noticing, hey, I'm triggering this, I'm making the situation worse, and you've tried all your de-escalation techniques that I just mentioned, and it's still not incredibly effective, take a break. Go outside, ask, hey, can I get you some water or something like that? Bring somebody else in for that moment, because it's not a pride issue when it comes to de-escalation. The goal is just to help this person across from you. All right, and then this is kind of the slide I was referencing. You just want to be supportive. Sometimes de-escalation is just being there and being this, like, what I call like the point person. And it's, I'm going to be doing all the talking. We're going to be, trying to solve this issue, trying to bring this person down from a 10 to a 7 or a 10 to a 5, whatever the number is. Sometimes de-escalation is being supportive, and it's being the person behind. It's saying, hey, do you need me to run and get anything? I can be helpful in this moment. These are totally different scenarios, totally different roles, but both are really important when it comes to de-escalation and supporting your team. All right, I'm going to pause here. I don't think I quite have time for all of the videos, but I just want to pause and see, do folks have questions, ideas, considerations when it comes to de-escalation?
There was a question placed that says, are there any concussion or brain injury studies that someone can attend who believes that they may have a brain injury?
Let's see. So just, are there any like research studies that a person can participate in?
Yes, I believe that's what the question is being asked.
Yeah, I mean, I'm not aware of any like locally, but I mean, my recommendation when it comes to diagnostics is like, if you have a local brain injury association, which you do, and it's a good one, calling them and saying, hey, are there any local like recommendations you have for physicians, local recommendations for psychologists or psychiatrists, like folks who would be involved in diagnosis. In terms of actual like research associated with brain injury, a lot of times it's entirely dependent on what's happening at your local, university settings.
Great, thank you. We just had another one come in from Cynthia. She wants to know, when you are working with a person that escalates when using telehealth, what different techniques might be effective?
Yeah, telehealth is really tricky. So when it comes to like working with somebody in telehealth, all the low and slow calming tones is like, it's really important, but also it's kind of like you want to have a lot more conversation about making sure that they're feeling safe, that they're comfortable. I'll do a lot of recommendation for like, hey, we're in this room. Is there somewhere else you could sit where you feel more comfortable? Like changing locations is a really effective tool when it comes to de-escalation via telehealth. If the person can move, if they're talking to you on their phone or a laptop or something like that. The other piece is just that the safety piece is different with telehealth. You inherently are a lot more safe. And so sometimes people will find themselves being more, I hate to say it, but more like combative or confrontational when it comes to telehealth. And so it's really, really important to note that just because you feel safe in this moment doesn't necessarily mean that you're presenting information in a way that's going to give you a better shot at de-escalation. So you kind of have to like pay attention to the way you're saying things, pay attention to the way you're presenting yourself. It's even more important in telehealth because all they have is the screen. It's kind of the same way that we have it right now.
Okay, thank you, Dr. Gomez. Right now, we do not have any additional questions, and we have about 9 minutes left if you want to try to do any of the videos.
Yeah, let's try and do that. Let me see if I can pull one up real quick. I'll stop sharing. Let's see here.
And while he is pulling that up, the videos that he is referencing are going to be on the slide deck on the last slides that are provided.
Okay. Let's see here. So the big thing with this video is I kind of show it to folks because I think it's an important way to see. This video shows the first 2 minutes of like, it's really, really what not to do when it comes to de-escalation. And then the next 2 minutes are like, this is exactly where you want to be. It's a very short video. I highly recommend when you're watching it, just be thinking, how would you respond in this moment? And then we can talk a little bit about it afterward. All right, let's see here. Okay, so this should be functioning. Let me go ahead and share. Okay. All right, this is my favorite video here. Hopefully folks can see this okay. 2 caveats. There's some language in this video. It's de-escalation. It's also, interestingly, this is a video from the UK, so it can be a little bit challenging to understand. My recommendation, again, just pay attention to the body language. The body language is everything in this. All right, we'll go ahead and get started here.
Someone's been in my bedroom cupboard, and I know who it was, and they took it. I want a doctor.
What's the matter, Ben?
I've just been on leave seeing my mum, haven't I, right? And I come back, and I've gone to my wardrobe, and my phone's been nicked, and I know he's taken it. I know he has.
Okay, you're going a bit too fast for me, Ben. Why don't you sit down and take a seat?
I don't want to sit down. I want him to give me my phone back. He's taking it to wind me up.
Who took it?
Philip.
How do you know he took it? Have you got any proof?
I know what he's like. He's always nicking stuff, and I'm going to fucking do him.
Did you see him take it? Did you see him go anywhere near your cupboard?
I've been with my mum, haven't I? Hey, I mean, he had 3 hours. That's when he must have done it.
Well, did any of the other patients see him take it? I think we should ask first of all, don't you?
I don't know.
Have you looked anywhere else apart from your cupboard?
Look, he took it. I know he has, and I want him to give it back. And if he doesn't give it back, I'm going to do him, and I'm going to smash his place up.
Well, let's just ask the other patients first to see if anyone's seen it.
No
did you
fucking
take
way.
it home?
I know he...
Let me finish. I was about to say, did you take it home with you?
I didn't take it out.
Look, Ben, you're most probably upset because your leave's over. Lots of people...
No, I'm fucking not. Philip's got my fucking phone.
But you don't know that, do you?
Don't tell me what I fucking know and what
That's
I've done.
not what I'm trying to say.
Yeah, what are you trying to say then exactly?
Look, I'm just...
Don't touch me.
Look, calm down.
No,
will
you calm down.
Oh, this is ridiculous.
What? That I've had my mobile stolen. You think I'm lying? Is that it? Easy.
Okay. I'm just going to pause that for a second because I think the things to pay attention to, notice the positioning of the body and how that changed. Notice how he stood up and the way that he stood up. Notice the way he was responding. It was very, very confrontational. Obviously, these are all things that like you wouldn't want to do in a de-escalation, but what I want you to pay attention to is this second bit, just the first couple minutes of it. You'll notice a drastic shift. And what's important about this is the same type of situation. The person coming in is coming in with the same energy, but the response is totally different.
Someone's been in my bedroom cupboard, right? And I know it was, and they took it, and I want to see a doctor.
What's the matter, Ben?
I've just been on leave seeing my mum, haven't I? And I've just come back. I went straight to my cupboard, right? And someone has taken my mobile. He's been in there and he's taken my mobile. I know he has.
So who took it, Ben?
Philip.
Did you see him take it, Ben?
Well, how could I? I was on leave, wasn't I?
Of course. What sort of mobile was it?
It's a Nokia, and it's got a camera. I only just got it.
A Nokia. You must be really angry, right?
Yeah, well, I didn't want to come back anyway, right? But I do, and I see someone's nicked my mobile, right? And I've had it up to fucking here.
Yeah, I can imagine. Listen, why don't we find somewhere to sit down and we can work out how best to get your mobile back, yeah?
Well, yeah, but we can't just sit down. We've got to go talk to Philip.
Why don't you come with me? We'll find somewhere quiet to sit down and talk about your mobile.
No, we've got to go back. We've got to go and talk to Philip and look in his cupboard. He's nicked it.
It's the best thing.
But
I'm just
I didn't
taking
even
him
want
into the quiet room.
We need to go and talk to Philip.
Let's have a seat, Ben.
I don't want to see it. I don't want to see it.
Okay, Ben, I'm going to sit down. Are you going to join me? We won't be interrupted here. So tell me what happened.
Well, it's like I said, right? I'm on leave and I'm seeing my mum, and then I come back here and I go at my cupboard and my mobile's got right, and everything else has been like trash. I mean, for fuck's sake, you do not muck about with other people's cupboards. It's just wrong.
Quite right, Ben. Your cupboard is yours and yours alone. Listen, this might sound like a stupid question, but I've got to ask it. Are you definitely sure you left your mobile in the cupboard?
Yeah, I don't take it out in case I lose it.
Okay. And you were saying you thought that Philip took it?
Yeah, to wind me.
Okay. This kind of goes the same way basically throughout this presentation. But what I want to just point out again is you'll note the way that this person responded in the second part of the video is so drastically different. And all the things that he did was just minding and being careful about using respectful language. He stood up when he needed to stand up and was with the patient. And then when the patient decided he wasn't going to stand up, he asked if he would sit with them. Like all of those little pieces are just, you can notice that like de-escalation is a lot about just the energy that you're projecting to this person across from you. And so I have 4 of these videos. I do recommend taking a look. I've kind of highlighted them for you, which ones I think are the most effective. But the reality is just like seeing it done is one thing. These are very, very, very challenging skills to enact in like a one-on-one setting. So it does take practice. So maybe like the thing to just pay attention to is just give yourself grace. De-escalation is really, really challenging. All right. And I think that's what I have for today.
Great. Thank you very much, Dr. Gomez, for your presentation today. And thank you to the Adept Institute of Maine for hosting the webinar. And thank everyone for joining us today, and have a good afternoon.